Chronic limb-threatening ischemia is a major pandemia. It goes hand by hand with the increase in the rates of diabetes and chronic kidney failure around the globe. And one of the things that we have found and identified is that there's very strong patterns of disease of the tibial vessels, so vessels below the knee. And as you get into these patterns, you realize that there's a multitude of lesions, and maybe not all lesions require treatment. So as an operator, it's actually very interesting, or actually I would change that. I said as an operator, it's baffling to see that there's all of these exuberant areas where we could put wires and catheters and tools. But the question of what we can do is not as important now that we have all these fantastic tools. It's what should we do, and how much is enough, and how much is too little. Patients that have chronic limb-threatening ischemia are a variety of patients. They go from patients that have very simple wounds to patients that have very complex wounds. And in that, there's obviously thresholds of ischemia. And so for us, it's important that we start dissecting the subtypes of patients and understanding what their needs are for each patient. And in that sense, there's a vacuum. I believe there's a niche. Because as we go into the suite and we look at all the options and all the target vessels and target lesions that we really have very few objective performance goals to know that we've actually accomplished a good revascularization that meets the needs of one particular patient type. So we have a multitude of non-invasive ways in which we measure perfusion, quote unquote. There's obviously an inherited error in saying that because perfusion requires a measurement of flow through a particular three-dimensional structure of tissue. So what we measure are very indirect parameters, like pressure of blood flow in the toe, like an ankle brachial index, like SPPs or transcutaneous oxygen measurements. The issue with most of these things are that they become bulky. Number one, meaning that they can't really be done intraoperatively in a very simple way. Number two, that a lot of them only measure the forefoot. So if I give you a toe pressure, which is a very classic way of measuring, I'm really not telling you a lot about the heel of the patient, which could be ischemic and have a problem particularly. And then last but not least, it merits a lot of times technicians and extra people that need to be involved in that, and certainly not something that you could do ambulatory when the patient goes home. So I think that we have good methods that have been well proven, but have great limitations to become really part of the flow in the intraoperative period, and certainly, quite certainly not something that we could do to monitor patients remotely. So I have been working together with a group of scientists from San Francisco in the production of a microsensor. This is an oxygen microsensor. It's actually a small, very small element made of gel that goes into the body. It is biocompatible, not bioabsorbable, now by the name of LUMI. And so this microsensor, when it gets inserted into the body after about 24 hours, it starts giving a very strong and very stable signal based on luminescence of the amount of oxygen in and around the milieu where that sensor stays or is inserted into the patient. And so the interesting thing about this is that you could, number one, target areas of the foot that you really have interested in knowing how they're behaving or how they're doing. And number two is it's ultimately a live feed. So now you potentially have eyes and ears into the tissue that you are working in. And so as you're doing an angioplasty and you're, to give you an example, unsure if you need to tackle that one distal lesion because you already tackled a lot of it proximally, then this could potentially give you a bar of safety and efficacy for your intervention. At the same time, it creates a language that we can relate. When we're not necessarily the one that does the foot surgery or the remodeling of the foot, it's the common language that one can eventually envision having with the podiatrist or with the foot and ankle surgeon, where we can relay, this is what we were able to do, and that allows you to then react to that information. So I think it's going to be interesting to find this as we move on. There's a study now going on. This product goes a few years back, but now we have, it's got now European, it's got a CE mark. and we have been running a study, a multi-center study called Omnia. And the idea with Omnia is nothing but measure patients that have chronic limb-threatening ischemia through their interval of care, from the baseline to the intervention to the wound care. And within those 6 months that are critical for these patients, we look at how they do. And so it's been actually very interesting to see what we've revealed here at LINC. We have the initial very raw data of only 30 patients, but what we've been able to find is that there is a relationship of those that have certain levels of oxygen increase intraoperatively to the ability of them to heal. So certainly at a very primitive early stage, but the statistics and the mathematics behind the first 30 patients show us actually some very good signals that we may be faced to one of the initial and groundbreaking tools that will lead to safer and more efficient treatments for patients with CLI. So with this particular technology, the LUMI microsensors, it goes back to the first unmet study, which showed safety in the insertion. We got good signals, stable signals, and no reactions, despite the fact that all of the patients in that initial study were ischemic, which is a great concern for people to insert one. But this is a very small micro gel that measures 1 to 2 millimeters, and it's subcutaneous, so it didn't show any issues longitudinally. Now what we have data-wise, prospectively, and which was shown here at LINC, was the initial result of, or the initial patients from the Omnia study. The Omnia study are patients that are measured throughout their experience during their CLI treatment, from baseline to intervention and eventually to 6 months, by not only measuring the oxygen, but also measuring the toe pressures and the transcutaneous oxygen measurements, the ABIs, and the photographs of the wounds and how the wounds evolved throughout time. And we've got pretty interesting data. We're actually excited to show that depending on the amount of intraoperative oxygen increase, we could actually predict some of the models that we can tell very early on if a patient's actually going to have a good outcome and have wounds heal and progress in a positive way versus those that didn't. So I'm very excited. It's preliminary. I think that we have to be cautious, like with anything. Skepticism is good in science, but it'll be interesting to see where we go with this. So I would hope that we are going to continue to enroll patients in Omnia. I think Omnia should reach a hefty amount of patients that would let us get all these variables and analyze and dissect them. I think we're going to have to get better at also marrying not only the intraoperative data, but also the longitudinal data. And then certainly adding some physiologic stressors to this, because we've also identified that there's a group of these patients that have sympathetic disorders, probably due to their diabetes. They have some dysautonomic issues that leads to worse outcomes, and we can identify that with very simple exercises like raising the leg up for 5 minutes and then putting the leg down for 5 minutes. And we're actually good at capturing which patients have that sympathetic disease. So I think as we unite more variables and we see more patients longitudinally, we may potentially get something really good.